And today we'll be talking about the cyanotic part. So cyanotic is always more dangerous, right? So this is where you need to diagnose it with perfection. So that's why I'll be showing you one very specific method about how to diagnose it, right? And all those things, they are known to you. I'll be just compiling it. You know how to see the ECG. You know how to see the X-rays. You know very well about the pulmonary and the systemic circulation. You know about both the blood pressures. So bas, that's it. This much is needed. It is a matter of compiling everything, right? All right. There was an email. I'll not take the name, but see, you don't have to worry about. कई बार होता है, मतलब in case English में problem हो, right? बिंदास आराम से just message. I'll explain the same thing in Hindi. The idea is आपको समझ आनी चाहिए. That's more important. Okay. बाकी no formalities, कुछ नहीं. Whatever, anything, anytime you can ask. Some of the questions when we are explaining some concept, right? When we are discussing some concept, and if the question is out of thin air, which is not concerned at all with that topic, तो मैंने वो question skip किया होगा, right? Otherwise, there is never an intention कि आपका question skip करें. Anything which is related to the topic, I always integrate it. Sorry. Let's start. It's time to start. So welcome back after Diwali. And today we'll be talking about part 2, right? So it was CHD, that is the congenital heart disease. And we discussed that it was part 1 and part 2. The main thing about the part 1 was that it was acyanotic. Acyanotic means baby was not turning blue, so baby was remaining pink. The most important conditions which were coming into this group were ASD, VSD, that is atrial septal defect, ventricular septal defect. And when we said that this was left to right shunt after birth, right? This was one of the email. Yes, before birth it was right to the left shunt, but this is after birth, right? So after birth, because the left side has got higher pressure, so blood was getting pushed onto the right side. So it was atrial septal defect, ventricular septal defect. After that, there was patent ductus arteriosus, right? I'm writing in short only. Patent ductus arteriosus, which should have closed, but still it is remaining open after birth. And finally, it was coarctation of aorta, in which the classical feature was inferior rib notching, which is because of tortuous intercostal arteries which are pulsating, right? And they are knocking off the lower edge of the rib, and thus we were getting that notch. Notch means that this is the inferior surface. So notch is like this part, right? And then as if there is a khada, right? So this is the rib. This is the rib. So practically speaking, yes, the rib is broken, right? Rib is knocked off from that point, and that is the classical thing. Such things, they are called as the spot diagnosis, right? It is called as spot diagnosis. आपने एक ने mail में पूछा था, what is spot diagnosis? Well, as you will come into the final MBBS, even in first MBBS, there used to some viva, right? जब viva लेते हैं तो कुछ चीजें ऐसे रखिए. You have to just see it and you have to answer. No details are asked. Nothing is asked. Simply it is said that, okay, this is clavicle, right? Take the pointer, right? Take the pen and put your pen onto that surface, which is the weakest area of the clavicle. That is the point where the clavicle can break, right? This is a very basic question which I'm asking, which I'm telling. So because clavicle is S-shaped, so that is the curve. When the clavicle changes its shape, that is the area where it breaks easily. Commonest, fallen outstretched hand. Outstretched means heart is like this. And if someone falls, this is like a huge long topic. Right from the clavicle, it can break even the scapula, then onto the femur, onto the elbow, and then the Colles fracture. Right? All these fractures, they are coming in line. Nothing complicated. It is the line of force which is passing. So at every point, when the line of force is passing, so that it is passing the forces from appendage to our axial structure. That is from the sideline to the central line. Right? These are the points where it can break. Right? More when it will be discussing upper limb. So here it was a cyanotic. आज डिस्कस करेंगे साइनोटिक. साइनोटिक का मतलब है ब्लू, राइट? बिकम ब्लू. द बेबी विल टर्न ब्लू. So you can say blue baby. Obviously blue baby, so it is dangerous, right? So here, without any doubt, we can say that in our pure blood, that is the blood in which there is oxygen, the carbon dioxide is coming and getting mixed. So that means this one would be the right to left shunt, because it is the left side which will be supplying to the entire body, right? And that is where we are, the deoxygenated blood that is getting dumped. Right? So that is what really happens. Things they were very good in ASD, VSD, patent ductus arteriosus, coarctation aorta, pretty straightforward. Now over here in cyanotic, you will be watching lots of combinations. It won't be one thing. It would be several things. 2, 3, 4, 5 things they can occur together, and you have to diagnose all 5 of them, right? So that's why over here, that understanding that will be very vital. So here comes the cyanotic congenital heart disease, in which it is right to left shunt, and these are the conditions. Now, don't be scared by such big names, right? Tetralogy of Fallot, transposition of great vessels, persistent truncus arteriosus, hypoplastic left heart syndrome, and total anomalous pulmonary venous return. And then we'll be discussing some vascular malformation. No worries. If you understand this one, rest all is very easy, very easy. Right? But this first one, you have to pay extreme attention. Just remember, in all the cases, it is right to left shunt. That means our pure blood. Pure blood means that is the blood which is having oxygen. In this blood, carbon dioxide is entering. Deoxygenated blood is entering. So entire body will be getting the mixed blood. Right? And think from the perspective of a kid, a bacha, right, who is just born. Okay. Vascular malformation, aram se we'll talk about it. So here comes the tetralogy of Fallot, the first thing. Yes, good evening, Kushi. So here comes the first symptom. Anyone, right? Okay. So anyone who has recently joined, right? We are discussing cyanotic heart disease, and this is the first condition. So even if you have missed the first 10 minutes, not to worry. Yahan se we are starting fresh. Right? So we are discussing cyanotic heart conditions, and these are the conditions. So right now it is tetralogy of Fallot. Baki ki 4 conditions, as it will come, we'll talk about it. Right? So here comes the first one. Tetra means 4. So there will be 4 conditions. Of Fallot. Fallot is name of the doctor. Louis Arthur Fallot. Right? Doctor. It is Louis. Right? Louis, but S is silent. Louis Arthur Fallot. So he was the person who first identified that yes, these are the things. Yes, Saturday there was no class. That's right. On Saturday there was no class. So many times people cram, right? Pulmonary valve stenosis and right ventricular hypertrophy and then ventricular septal defect and overriding of aorta. And if one thing is missed, gone, right? Especially when there is VIVA. So what we'll try to do is we'll try to make our standard heart, right? And today you'll be drawing these images along with me. Right? So when we say draw standard heart, very quickly, right? This is left atrium, left ventricle. From here, it is the just right A, it is aorta. This one is the right ventricle. From here, it will be the pulmonary trunk. And this one would be the right atrium. This one would be the tricuspid mitral. And from here, they will be the pulmonary veins. And from here, it is the superior vena cava and the inferior vena cava. That's it. This is the whole layout. Now I change the color, taking it to red. First, pulmonary valve stenosis. Right? In this order only, we'll remember. So here is the pulmonary trunk. So pulmonary valve will be over here, right? So we'll write as 1. Pulmonary valve stenosis. Name itself is sufficient. Pulmonary valve is stenosed. Stenosed means it is shrunken. It is not opening to its full capacity. So that means what would happen, right? And let's do one thing. Today I'm allowing you to unmute by yourself, right? You'll be able to unmute yourself. So you can talk to me. Unmute themselves, right? You'll be able to unmute yourself. So if you wish, you can ask. You don't have to type. You can ask straight. Okay, I've done that. Just test it. You can unmute now. Test kar lo ek baar. Ha, I heard someone. So do talk, because now see the presence is dropping, right? And I'm telling you, it happens every year, right? And as the presence drops, then it comes to like that classes are terminated. So truly speaking, yes, I feel bad, but so Bindas, talk to me, right? Okay, so here it is, the first one, pulmonary valve stenosis. So this is the pulmonary trunk, so that valve is shrunken. Right? So what would happen when this valve is not opening? What would happen? What would happen? Either type or speak, say something, interact, come on. What would happen, right? This valve is not opening, right? This right ventricle is trying to push the blood, but this valve is not opening. Right? It is opening slightly. So there would be
increase in pressure.
Correct. You are right. You are right. There would be increase in the pressure, and that is what is called as the back pressure, right? So pressure in the right ventricle would rise, correct? Right ventricle, because there will be increase in the back pressure. So this right ventricle, for him, right ventricle is like now doing exercise. So this right ventricle would be, it would be enlarged, hypertrophy. So that's the second thing. So this was our first thing, right ventricular hypertrophy. This is the second thing. Correct? Makes sense? Third, there is ventricular septal defect. Ventricular septal defect. Right? So there is a gap. So that's why we just write it over here. This is the third defect. And the fourth is the classical one. This is overriding of aorta. Okay. Aorta, it comes out of left ventricle. Now over here, I would say you draw the aorta like this. And do write aorta and give it over here number 4. Now what we have done is, we have shown that aorta is coming out of right ventricle as well as left ventricle. Right? Right ventricle as well as left ventricle, and it is variable. That's true, it is variable. Right? We'll be discussing in detail in a minute what exactly it means, but if you know this, wonderful, all clear. Tetralogy of Fallot is comprising of 4 things. Sometimes, right? Sometimes there is pentalogy of Fallot. Pentalogy. This is one of the favorite Viva question. Pentalogy of Fallot, which is the extra thing. Well, it is the AST, atrial septal defect. So you'll be writing it like this, and you'll give number 5 over here, right? So this is the thing. So now at your place, right, you will repeat that first was, when I'll just say one. Don't even look at this, right? Just try to from the figure which you have drawn. One was pulmonary valve stenosis. Can you please repeat previous topic one more time? Which topic, Sally? Which topic? Previous topic means this is the first topic. If you have joined just now, this is the first topic, right? We have not done anything. So, third point. Achha, third point. Third point is, we are repeating all the points. We are repeating all the points. So first one was pulmonary valve stenosis. Make sense? This is the right ventricle. From there, the pulmonary trunk goes out. When the pulmonary trunk goes out, so there is a valve, right? There is a valve. So when this valve is stenosis means it is you are unable, that valve is not opening in your patient, right? So the amount of blood which should pass is not passing, so there will be the back pressure. So this is the first thing, pulmonary valve stenosis. The second is, because of the back pressure, right ventricle is hypertrophic. So that is the second point. Third point is ventricular septal defect, right? Now, so you guys are expert in that. We discussed it in the previous session, right? Ventricular septal defect, right? Inlet, outlet, membranous, muscular, that is trabecular, and all of them. So third, that is the third point. Fourth point एक बस समझना की जरूरत है. Aorta comes out of, we know that it is left ventricle. Right now, I'm making you draw in such a way, this is whole aorta. Part of it is coming from right ventricle, part of it is coming from left ventricle. Aisa kaisa? Wait for a minute. But this thing is number 4, which is called as overriding of aorta. And then fifth one, this when fifth condition is also involved, right? This one, which is ASD, atrial septal defect. Right, we have discussed that also. So then it is called as the pentology. Penta means 5. Okay? So that is called as pentology. Why we are understanding this thing in so much of detail? Because we will be surprised that in what detail we go. Right? I'll show you CT scan, angiographies, diagnosis. We'll see the ECGs, the entire diagnostic procedure. Because if you know, so then automatically you become the pediatric heart expert. Because this is the most common, 50 to 70% of congenital heart disease. So when you'll be going into your pediatric talks, right? So where the newborns will be coming, in case, right? Most of the time, the congenital heart disease will be tetralogy of Fallot. You'll be watching it so many times. So that's why you need to diagnose it very precisely, because this is the most common. And then 10% of all congenital defects. Now, all congenital defects means the defects which are related to head, defects which are related to brain, defects which are related to bones, muscles. You comprise of everything. And out of that, 10% is tetralogy of Fallot. Imagine if baby has got some immune problem, baby has got some chromosomal problem, baby has got some osteogenic problem. Combine, make a full list of them, 10% to tetralogy of Fallot. So important, right? So this is that important. This is seen in what I'm about to explain is, this is one of the favorite, again, USMLA question, and also the question when it comes to किसी को परेशान करना हो. Seriously, at times this question is used. Tetralogy of Fallot, which chromosome? And then they go into the detail. Yaad rakhna is very simple. First, I'll write down, it is like one complete address, right? Let's pick up Anuja I, right? Say, for example, if I say Anuja I, right? And randomly I'm picking up, right? Let's say you are from Mumbai. I go to Mumbai airport and I shout Ahuja. What are the chances that how many people will be there with the same name in Mumbai? So many, right? Then we go to that area. So again, in that area also there is possibility. But when it goes to that society, that house number, and right, then it becomes so specific. So specific. Even at this address, right? His brother, sister, father, mother, they are there. Right? Everyone has got the same address. But you are the most unique person who is having this name and this address. This makes you the most unique person in the entire world. There cannot be any other person in the entire world who will be having same name and same address. Simple. And same thing is true even for computers, right? So these are your MAC address. These are your MAC address, and these are your IP address. And that makes your machine, your computer, your cell phone the most unique cell phone in the world. That's why it never ever happens that you get a call and by mistake our PM Narendra Modi has called you and he was supposed to talk to Donald Trump, right? It never happens, right? So same way, this is what is called as the addressing system. And you'll be very happy to know that there is wonderful addressing system even into our entire chromosomal pattern. So here it is, when it is said that it is the chromosome 22 deletions. Chromosome 22 deletions, so is that the whole chromosome is deleted? Right? There are, see, 23 pairs, right? 23 pairs of chromosomes, total 46 chromosomes. There is address, it is called as 22q, right? 22q 11.2. Now it has got a meaning. 22, though it makes sense, it is a chromosome number, right? This is a chromosome number. Chromosome number. Now chromosome, how it is, this is a centromere, right? There is a short and there is a long arm. So this is called as P and this one is called as the Q. Easy enough. So that when we say Q, so that means we are dealing with a long arm, right? So this is the 22Q. Up tak to easy. Then this entire thing is divided into, that is called as the regions. So when this particular one, it is the region 1. Then this region is once again divided into bands. So then that is called as the band. So this is the first band. And after dot, whatever is mentioned, that is called as the subband. Subband. In genetics, we'll be going into still more detail. But this much if you say, so then 22q 11.2. So basically, what are chromosomes? Chromosomes are nothing but they are the blueprints. They are the blueprints, the very secret codes which will be making specific proteins, and they are made up of all those protein base pairs. So at this location, 1.5 to 3 million, right? Million base pairs, when they are deleted, right? These are deleted. These are deleted or corrupted. So then that thing would lead to the condition what is called as the DiGeorge syndrome. This is one of the very favorite question in USMLE. It is called as the DiGeorge syndrome. Now DiGeorge syndrome, in that you'll see tetralogy of Fallot in your patient. Now in tetralogy of Fallot, right, you have detected it, but you will find that DiGeorge syndrome, because of this deletion, it is also associated with some thymus disorder. So when the thymus is affected, that means immunity would be affected, right? It would be associated with some parathyroid abnormalities. So that means it will be affecting the entire metabolism. It will be affecting the corticosteroids, right? So this, whenever, and one thing, whenever the deletion is less than 5 million, right? When the deletion, if it is more than 5 million, so then it is a very big problem, right? The problem of survival. But when the deletion is less than 5 million, 5 million base pairs, so then we'll be calling it micro deletions. Micro deletions. This is just for the so in tetralogy of Fallot, why it occurs? Why so many things are occurring? Because the thing is that this important area, that is 22q 11.2, that is affected. Right? So here is, so first we see this. This is a very typical thing. Right? It is, you have to watch. This is the boot. This is the boot. That's how the X-ray would really look like. It is called as the boot-shaped heart. So when you take ventral, so this is what is called as the boot-shaped heart. Boot-shaped heart sign. And how is it? So if you see, right, if you make an outline, and if you make an outline like this, very typical, boot-shaped. And in that, will be marking 3. 1, just 1, then that toe, this is 2, and then this base part, that is the 3. Right? So it is a boot-shaped heart. This is in French, this is core and sabot, right? This is also called as clog shape. This is also called as clog, right? But let's keep it simple. This first one, upper part of the boot, this upper part of the boot, right? This upper part, that is bulged. It is because of pulmonary trunk, right? It is because of the pulmonary trunk. The second part, the toe of boot, it is towards upward pointing cardiac apex. Now, cardiac apex is what? Cardiac apex is this. This is the heart, and this is how the heart normally is, right? So this portion, this is the cardiac apex. Cardiac apex. Now we know that this cardiac apex is formed by whom? It is formed by the left ventricle, right? It is formed by the left ventricle. In front, who is there? It is the right ventricle. Now, right ventricle is not only in front. Right ventricle is also at the base. You know? Right ventricle is at the base also and in the front also. So our standard figure, which was like this, and here is the right ventricle. It's not to the proportion. Just take it. Right ventricle is here. And this one is the left ventricle. But it is at the base. So when the right ventricle is enlarged, so it is the base which is also lifted. When the base is lifted, this cardiac apex, right? Apex means something, that point is lifted. Right? Because left ventricle remains of the same size. Because right ventricle enlarges, so it lifts. Because it is the diaphragm also, at the diaphragmatic surface also, that is right ventricle, so which is enlarged. The front is also enlarged. So that's why it gives this type of typical shape, thanks to right ventricle, right? So that is the toe. And this third one, that round shape, that is classically because of the concentric right ventricular hypertrophy. Concentric means all the muscles, right? You know say, this is the structure. If it is enlarged like this, right? So this is focal enlargement. Focal. Only one portion is enlarged. But when things are like this, right? The entire, so then this thing is called as the concentric. This is called as the concentric enlargement. So over here, this keyword, do remember, concentric right ventricular hypertrophy, that's all the muscles are hypertrophied. So that's why it is giving this appearance. Right? Now, this is like a very typical case. Very typical case. So, बिल्कुल मतलब ऐसा केस देखने को मिले तो you can diagnose very easily. But we need to see something else. And that is, before we proceed, we need to, because that's the thing over here, we need to see what is overriding of our. Now let's go back to our histology, embryology. Right? In embryology, we knew that there was truncus arteriosus, which was like a common tube. On truncus arteriosus, there was a formation of septa. Right? There was a formation of septa. So that septa, which was leading to formation of pulmonary trunk. So pulmonary trunk was getting developed. Remaining portion was getting twisted, and that's how the aorta was getting formed. So that was the aorta. This aorta was coming out of left ventricle, while this pulmonary trunk was from right ventricle. So far, so good. Right? This was a normal process, right? Which was the truncus arteriosus. What if it happens like that the septa is formed, but that septa is not exactly into the center, it is on one side. And the aorta, it becomes bigger, so big that if we really draw our heart like this, then that aorta is emerging from left ventricle as well as right. Left ventricle as well as right ventricle. I'll show you angiography, so that will make things much more clear. But this is the idea. It is called as the overriding. How? Because when the aorta, right, just visualize, you have seen the heart. The aorta goes like this, right? The aorta goes out from the left ventricle. And then from here, the pulmonary trunk goes. What is this? This pulmonary trunk is pushed and aorta takes that space. So this portion is of right ventricle, right? So here is how it looks like. See this. There are multiple images. So today's session is like, just watch the image and you will understand. Right? So here is the angiography, right? That's the left ventricular angiography. See, this is the catheter. From that catheter, we have put the dye into the left ventricle. So here is the left ventricle. Right. Keep the color. So this is the left ventricle. Fine. From left ventricle, this is VSD, ventricular septal defect. So dye is going into right ventricle also. Chalo, theek hai. So far so good. So here is the right ventricle. The dye is getting spilled into the right ventricle. That's good. But then here is our aorta. Here is our aorta. This is AAOA, is ascending aorta. See, this aorta is coming from the right ventricle also and the left ventricle also. The formation of the septum, which should really separate right ventricle and the left ventricle, and the aorta emerging only from the left ventricle, that aorta has shifted. It is overriding. It is overriding the right ventricle. So that, see here, it is emerging from right ventricle as well as left ventricle. And then there is ventricular septal defect, right? So that's over, the entire valve would be over here. Right? So thus, now it is easy that you will be finding in this particular patient the mixed blood. The blood will be coming from right ventricle also and it will be coming from left ventricle also. Both of, right? And then it is getting distributed to the rest of the body, right? So this is what we see in the angiography. If we take a CT scan, right now, this image is of CT scan, zoomed, right? Pretty zoomed. Here is the left ventricle, here is the right ventricle, and this is the VSD, ventricular septal defect. And we can see that the classical aorta, right? And that classical aorta is coming out of both. Right? This thing is called as the overriding of aorta. This is a classical picture of tetralogy of Fallot. Classical picture. Right? So thus, we were understanding that there were four things. First one easy, second one easy, because first, the moment you say pulmonary valve, right, there is stenosis. Then second was right ventricular hypertrophy because of that. Third was ventricular septal defect. And fourth is this overriding of aorta. Right? Never miss. And fifth one, in case of pentalogy of Fallot, there was the atrial septal defect. This was a reason that we discussed VST and AST in advance. Right? So that now things won't be confusing. So here it is. We can see two things. We saw two things. One, the VST, and second is the overriding of aorta. Question. Have you understood what is overriding of aorta properly? Is that concept still clear?
Yes, sir.
Good. Or, okay, great. Right? Or if it is not clear, to bata dena. Right? We'll be able to see it several times, but kuch bhi problem hai to bata dena. Now, let's come to ECG. Your patient has come. Right? Patient has come, and the moment you see the patient is a bit bluish. Patient jaisa dikhna chahiye, baby. Patient means baby. Right? Is not looking that pink. Right? You immediately go for X-ray. X-ray, you find this boot-shaped heart. Second thing you should do, immediately you go for the ECG. Because easy to do, right? Instantly you'll be able to do that. Over here, now tell me, we have learned ECG. And in ECG, if I say right ventricular hypertrophy, the first thing, the moment ECG is taken, Right ventricular hypertrophy means right axis deviation, correct? And right axis deviation के लिए what will we watch? We'll watch lead 1 and lead AVF, correct? We draw circle, right? This is normal. This is right axis deviation. This is left axis deviation, right axis deviation, left axis deviation. And which lead we have to watch? We said that we have to watch lead 1 and we lead AVF. So how do we say RAD? RAD means if these both are plus plus, so then it is normal, right? But when this lead 1, right? When lead 1 is minus and this AVF is plus, so that means we are dealing with a right axis deviation. Right axis deviation, so then we jump to our that shortcut, you know, R2. That means AVR, right? N2. So when we are over here, so heart is either like axis deviation is here or here. This is so this is left axis, right axis deviation. So if right axis deviation, then it is either this is 90 degree, so either it is 120 degree or it is 150 degrees, right? So this 2 is what? 2 is 150 degrees and this one is 120 degrees. And what we have to watch out of these, which one is isoelectric, right? That is whatever the upward deviation, same is the downward deviation. So we call it isoelectric, right? Isoelectric. And then we just watch it and you guys know this thing so well, right? Within seconds. I think we did that thing in 10 seconds, right? We could figure out that yes, there is the right axis deviation. That's right, coach. So RAD we have diagnosed, but is RAD associated with right ventricular hypertrophy? Well, again, a matter of 10 seconds. The right ventricular hypertrophy will be going for the chest leads, right? V1, V2, V3, V4, V5, V6. So V1 was here all the way up to V5 and V6. Now R is rising and S is sinking, right? R means there will be tall waves, S will be there will be deep waves. Right side of the heart is big, so there will be massive current. So this is V1, there will be massive current, more current. So there will be tall R waves, right? And then V5, V6, they are very far, and they are very far. So they'll be watching how dur se current, right? It is going. So it will be deep S wave. Make a total of both of them, and that should be more than 35 confirmed, right? This is the right ventricular hypertrophy. Done. Next, right atrial enlargement. Amazing. Atrial, that means the P wave is involved. Right atrial enlargement, that means it will be giving biphasic P wave, correct? What do we mean by biphasic? That is when the P wave is actually formed, right? It is the right side, left side, and that's how the P wave is formed, right? But now, because the right atrium is so big, that's why we'll be getting it like this, right? This is how we'll be watching it. So that is what is called as the biphasic P wave, which is confirmatory sign of the right atrial enlargement, because the first part is of right and this part is for left, right? So that's why, see the ECG, importance of ECG. You see the extra chest, right? You see the ECG and you start speaking, right? So it is like under 1 minute, you'll be able to speak so many things. Now comes the symptom, how the patient will be presenting. See the amount of pulmonary blood flow, right? Because this would be the third step. In fact, CT scan would be the third step. Right? Because normally, angiography is an invasive procedure. CT scan is not an invasive procedure. Straight away, you just put the patient into CT scan, and now the fast CT scan, fast slicers are there. So within 6 minutes, the images, they are in your hand. So it's much faster. In case of angio, you have to plan. So symptoms, there will be amount of pulmonary blood flow that will be playing a major role into the system, because it is like the right to left shunt. This is the right to left shunt. Why do we say right to left shunt? Our overriding of aorta, right? The overriding of aorta, that means right ventricle is straight away pumping the blood into the aorta. So obviously that blood would be desaturated. Right? So there would be decreased exercise tolerance, but natural due to systemic desaturation. Systemic desaturation means tissues, they are getting less oxygen. So when they are getting less oxygen, so that means there will be decreased exercise tolerance. Patient with TOF, TOF is tetralogy of Fallot, may show signs of heart failure. Right? May show. This doesn't occur immediately, but gradually it occurs. The reason? Fluid overload. Right? See, because of the ventricular septal defect, right, the blood would be pushed into the right side. Right side is becoming bigger and bigger, right? Then that blood that is getting pushed into the aorta. So everything is becoming massive. At the same time, in the lungs, the amount of blood which should go, that is not going. Why? Because there is pulmonary valve stenosis. So this is the pulmonary trunk. Less blood is going towards the lungs. So due to this, the blood is getting pulled into it, and that is what is called as the fluid overload. Fluid overload. And as such, in those bachas, right, heart is weak, and on top of it, this is happening, and there will be poor feeding because all the systems, they are affected. Poor weight gain, and there would be tachypnea. Tachypnea, right? There will be abnormal rapid breathing. Why there will be abnormal rapid breathing? Because the amount of blood which should go into the lungs is not sufficient. If it is not sufficient, so then there is only one method to take that oxygen which is taken, which is patient is breathing, and breathe faster so that fatafat that CO2 is cleansed. Right? This is without cyanosis. Right now it is not developed, but then as the body's requirement starts increasing, it starts developing. Now see how the nature works on it. Some children who can walk, right, many times things are, they will just see the details, right? But some children who cannot walk, sometimes you will see that bar baith jate hain. They just sit. And how do they sit? They sit into that squatting position, squats, right? Now in exercise, right, when we do the squats, as if we are sitting on that invisible chair. So that's how we do the squat. Over here, what they will be doing, right? They will be into this position. Bop, right? See the they'll sit on the floor, bending their knees. Bending their knees. This is what is called as frequent squatting. This is one of the defense mechanisms. This is the reason they at times survive. Jinda reh jate. The squatting will increase pulmonary blood flow. Now, how come it will increase the blood flow? By squeezing systemic venous blood. Right? Systemic venous blood. Think it like this. In the legs, right? In the legs, there is venous system. When you bend, when the muscles are squeezed, that blood is squeezed out, right? So that venous blood, that will go into the inferior vena cava. From inferior vena cava, it will be going into the right atrium. From right atrium, it will go into the right ventricle. So it will be pressing, it will be pushing, right? So that because of this, normally jo blood flow hona tha, uski jagah thoda extra blood is going into the pulmonary system, right? So it is because of the squeeze. It is because of the squeezing of the systemic venous blood, right? So this is one reason. Again, this is one of the very typical question, very typical, but it is a question of Viva, right? And in Viva, in first year, if anyone asks you this question, then tap yourself. Boss, must kar rahe ho. Teacher has got no other option but to ask you this reason. Okay, in tetralogy of Fallot, can you really say why the kid, that child will be going into frequent squatting? The reason, first reason is that there would be increased blood flow, pulmonary blood flow, because the venous system is contracting. not only the venous system, every system is contracting because आप उल्टे पाँव करके बैठ जाओ, after some time you'll find कि यार मेरा पाँव सूज गया, right? That's what you feel. It is not only the venous system, but the arterial system is also getting compressed, right? So it is the femoral artery. Now this reason to is still super, still much better, worth understanding. So here is the now how the femoral artery is coming up, right? So this is the aorta, right? This is the aorta. All the way aorta, it divides into the common iliac into the external iliac, internal iliac, and then external iliac is nothing but it is the femoral artery. And it is the femoral artery which will be supplying to the entire lower limb. When the baby squats, right? So this femoral artery is bent, matlab dabi. When it is kicked, when it is compressed, so it will generate a back pressure. That back pressure will be transmitted to aorta. From aorta, aorta is landing into left ventricle, right? So this left ventricle, it reaches to this point, right? To the left ventricle. Now, what was happening? What was happening? The pulmonary valve, right? That is stenosed. So right ventricle is now majboot hattakat, right? Right ventricle has become like a boss. Right ventricle was pushing the blood into the left ventricle. But when the aorta is landing into this, and aorta will generate the back pressure, that is relatively there will be increased pressure into the left ventricle. Am I clear? So it means that now left ventricle is also having more pressure. So the pressure with which the right ventricle was throwing the blood into left ventricle, that would be decreased because there will be decreased difference in the pressure, right? Previously, left ventricle was, suppose it was having pressure units, just random figure, 10, right? And right ventricle was having pressure of 20. So then it was pushing the blood. But now because of this femoral, right? Femoral is kicked, so blood will try to go there, right? Unable to go. So this would be the back pressure, that back pressure. So this pressure, if from 10 now it has become 15, so there will be less amount of blood which will be going from right side to left side. Right? This is the second reason by increasing, which is called as the systemic resistance. Why systemic resistance? Because femoral artery is compressed. Femoral artery is compressed, so it has generated the back pressure all the way to right ventricle, left ventricle. So whatever the blood which was coming from the right ventricle, that is decreased. When that is decreased, it means mixing has decreased. That means the quality of the blood which is getting pumped into the system, which is going to the tissue, has improved. So that's why that kid will walk and then will squat. And you will find that yes, from blue it has become a bit better. Then once again we'll stand, we'll walk, once again it will sit. So this is the defense mechanism. This is one of the defense mechanisms, right? So is this clear? Right? This point, very vital, very vital. It is asked even in post-graduation, each year. So कुछ भी जरा सा भी डाउट है, एंड दीज आर द थिंग्स, मैं बोलूं एक बार समझ लिया ना, then for rest of the life you will feel like कि चल मैं ये किसी को बताऊं. And actually I used to do it. Means I mean people would say crazy, but I was having that इतना छोटा सा, because in hostel तो you are unable to afford, right? इतना छोटा सा mirror का, तो looking into that mirror we used to say, गाली भी बोलते थे, sorry, right? But कि चल अब मैं, and how we used to do, you know, there were few actors, right? मतलब Amitabh Bachchan, Dharmendra, and that time, that say Gabbar Singh, you must be, right? Amjad Khan. So this is what we used to do. There was a movie called Sholay. So then this is what we used to do in our class. I mean in our hostel. कि गब्बर सिंह अगर जो समझाए कि why it happens like in के ये बच्चे, right, they will be doing frequent squatting. So then as if this Gabbar Singh is telling this reason to Kalia, right? So then things will go like kitne reasons, right? That way it would start. So it was a sort of fun, right? But then you never forget. But the point is, you speak to yourself, you talk to yourself. And when you talk to yourself, you'll be remembering it so crisply, and it would be a sort of rehearsal. And the best thing is, say, if you are, if means my father was like my friend, right? My father was purely in commerce, right? He was AGM Dena Bank. But I used to tell my father, कि, चलो daddy, आज आप सुनो कुछ मेरे से, right? And then I used to explain to him. Right? He was, I mean, so nice. मतलब he used to listen, and he used to ask question also. Right? So dad या mom, जो भी favorite हो पकड़ के देखो सुनो, right? समझाओ. And if they ask question, right? If they understand, draw कर करके समझाओ. Trust me, USMLE is very easy. USMLE, even in my batch, when I say na, so in that I keep everything open, right? All options are open. Matlab anyone can talk anytime, and it would be randomly like, chalo Khushi, explain, chal. Second point, explain kar, start, and it would be like start, and then there is no excuse for Khushi. She has to start immediately, right? So that sort of training it is, because there is only, ये याद रखना, whenever any question it is asked to you, if you don't reply within 3 seconds na, boss, even if you are world's best doctor na, your value is 0. You have to start within 3 seconds. This is a very known factor. It is a known fact in public speaking or in any of the interview, in anything. First 3 seconds, even when many of my students, they are like IAS, that is PPAS, Sardar Patel Institute of Public Administration. So I train many of the students, and later on they become custom officer. I mean, the commissioner of customs, right? He was my student. So once I was there, he said, "Arey sir, it's such a pleasant surprise." But there he said that this is the thing in IAS interview, they ask you the question, you have to start replying within 3 seconds. ये याद रखना. Viva में, why people fumble, you know the answer, but बस ये start लेने में तकलीफ. Do this practice right from the beginning, right from the first year, you will never face that problem. Okay? Let's explain this randomly. Anuja, unmute yourself. अब फंसे, because then you have to explain it कि हाँ I'll do the dual angiography, one angiography, वो फिर गए काम से, right? Unnecessary discoloration will start increasing. Hypercyanosis, right? Sudden occurrence of severe cyanosis, deep and rapid respiration, irritability, and then the lethargy. Because when the person is, think it like if someone is strangulating, gala dabai, to wo, that person will open his mouth, will be gasping, right, for the air, will start turning blue. So same thing is happening over here, right? Because the amount of blood which is getting pushed into the left side, that is so more, and so patient starts breathing deep and rapid respiration, irritability because of the more carbon dioxide, and lethargy. Patient will become एकदम थक के गिर गया जैसा, right? Lethargy, unable to move. Typically, this occurs around 2 to 4 months of age, because initially the requirement is less. As the body starts growing, tissue starts growing, they start demanding more oxygen, more nutrition, and then the trouble occurs. कितनी बार patient के parents को पता भी नहीं चलता, up to almost 3 months, 4 months. Then, if hypoxic spell lasts for a long duration, then at times they feel कि ये बच्चे को हो क्या रहा है, right? मतलब and typically they will, when they will cry ना, they will cry but without making the noise. Can you imagine, right? When the baby cries, मतलब full force, right? Here, when they will cry, तो right, they won't be able to, मुंह से आवाज ही नहीं निकलेगी, because the amount of air which is to be pushed, right? The muscles, they are not powerful even to generate the voice. So if hypoxic spell lasts for a long duration, without treatment, if no treatment, so then it can result in seizure, right? The patient will start developing convulsion, brain is getting affected. That is the hypoxic brain damage. This is the reason that it is necessary to diagnose it early, so that brain damage is not there. Because if our brain damage hua, whatever the portion of the brain is damaged, it is damaged forever, it can never ever recover, right? Brain and heart, they never recover, and then it can lead to death. To chalo better, but if it survives, so then it may lead to paraplegia, hemiplegia, other body paralyzed, right? Unable to speak, unable to drink, and then rest of the life, that is painful. One of my friends, he is a police inspector, and his daughter ko this thing happened. So when we met for the first time, I said कि राजन भी इसका एक्सरे वगैरह है? He said, हाँ है ना सर, तो शो मी. उनका क्यों ट्रीटमेंट नहीं कर रहे? The reason was, sir मैं बहुत बिजी था. Then one day I explained this entire thing. He cried. He said, sir मेरी गलती. I said, yes, तेरी गलती. Some things are to be, मतलब जो कहते हैं ना कि instantly it has to be come to the medical attention. Now, whenever you see this thing, I went with one of my friend at a place, and there was a sadhu, right? There was a sadhu, right? And he was like, सब मतलब प्रणाम कर रहे हैं वगैरह. What I saw is that he is having this thing. I said, sadhu ji, दूसरा तो छोड़ो, you have got the respiratory problem. You got the respiratory problem. This is what is called as the clubbing. This is called as the clubbing. This is one of the, as a medico, you can watch this thing in anyone's feet and hand, and if you see this thing, and this thing is dangerous. What it is, take your finger like this, right? Watch it from the side. Watch it from the side. Just a minute, just 1 minute. Watch it from the side. Right? So this is just 1 minute. Here, give me. Someone is coming. Okay, so you take your finger like this and watch the nail, right? This is how your nail would really look like, right? This is the pulp space of your finger, right? The flesh part, and then on top of it, this is your nail. This is normal. When this nail bulges, right? Watch this, drum like, right? So this nail bulges like this. Like this. Right? This is the indication that definitely there is a respiratory system problem. So you will find that in patient, see all the fingers, right? All the fingers. See the nails, they are like bulged, even in feet. So this bulging, this is what is called as the clubbing. Right? This is called as the clubbing. So when we say there is clubbing in fingers and toes, and then cyanosis in lips and fingers, right? Bluish lips, there the skin is extremely thin. So you'll be able to diagnose this bluish discoloration on the lips much earlier, also on the tongue. But tongue is, you have to tell, the lips you can see straight away, and the fingers, right? Because it is a peripheral circulation. So these are the diagnostic points. Diagnosis is stamped 100%. This is what we are dealing with. It is by echo. So on echo, this is what you see in echocardio, right? Echocardio is using the ultrasonic waves. So here we have got the right ventricle and the left ventricle, and this one is the aorta. This one is the left atrium, right? So over here, this one would be the mitral valve, and we can see that this aorta, right? This aorta, right? See the aorta. This is the right ventricular margin, right? It is big, and here is the communication, ventricular septal defect. They both are communicating, and both of them, they are opening into this aorta. So this is where you see the overriding of aorta as well as ventricular septal defect, and right ventricular musculature that is so much thickened, right? It is thickened almost to the same level of left ventricular musculature. So here three things, so they are confirmed, right? That is right ventricular hypertrophy, overriding of aorta, and the ventricular septal defect. So this is how you stamp that it is definitely we are dealing with the tetralogy of Fallot. For the treatment part, no other choice. This is the cardiac repair surgery ASAP, as soon as possible, because as it is getting delayed, right, the chances of that recovery, they decrease. And still, even after the treatment, it is about 86% of the people, they survive, they see their 35th birthday. They reach 35th year. Right? Only 86%, they reach 35. After that, it gradually becomes so painful that they pass away. Right? So hardly such patients, they reach adulthood without surgery. So if the surgery is not done, they hardly, they can't reach even up to the 5 or 7 years. What is needed? It is a major surgery. First one, ventricular septal defect is corrected. Well, you know that you'll be doing it with the help of implanter. Correct? We have seen the implanter, and that implanter, that is the ventricular septal defect. Its shape would be, right? It would be thicker one, and it would be same on both the sides, right side and left side. Right? So that is the implanter which you'll be using. Second, pulmonary constriction is relaxed. This is relatively easy, right? Pulmonary constriction, pulmonary wall constriction, that is relaxed. The third thing is right ventricular hypertrophy resolves. It resolves by itself as you decrease the pressure. But if there is overriding of aorta, if present, so then it has to be corrected, and this becomes a major thing, right? Because this is variable. This is variable. And it is not so that how much it will be overriding. So whatever it is, we have to correct it. So this becomes a major portion. So if it is asked which one is the most difficult portion, overriding of aorta, correction of overriding of aorta, if present, is the most difficult step. Okay. Next question, which is commonly asked, is what would be the complication? And for this complication, heart is a very sensitive system, extremely sensitive. So when we say that someone has got a myocardial infarction, heart attack, right, you have treated everything very well. But then remember, 6 to 8 hours, right, there can be development of ventricular tachycardia, ventricular arrhythmias. So there would be they will start beating at such a heart rate, and that thing can be fatal. Same thing is true even for this, because any of the tissue when there is insult means what? Any surgery is an insult, right? Because cut hua, right? Though your intention was to repair it, but as such for the body, it is cut. And even when we put an incision, so it is an injury to the body. So body would be reacting accordingly. So any injury, any insult to the tissue leads to disturbance into the electrical system. And when it comes to heart, it leads to what's called as the ventricular arrhythmias. Ventricular arrhythmias, right? Arrhythmia means everything related to electrical system. There are several types. Right? We'll be discussing it, right? But there are several types. So this is one of the major, and that's why this is called as a major post-operative killer. This was one of the questions. Major post-op killer. Everything has done. You have done fantastic surgery, but if this thing is not taken care of, it can cause problem. Right? And yes, you are right. In case if there is pentology of failure, then you have to repair the AST also, right? With the AST branch. That's right. We now move on to the second condition. And this second condition, this is the second condition. This was tetralogy of failure was first. This second condition is the transposition of great arteries. Transposition of great arteries. Two types. Two arteries we have got two major arteries. Right? One is our big boss aorta, and second is the pulmonary trunk. Pulmonary trunk. Thus, the entire game is of these two only. They switch position. Right? It means this is the heart. Right atrium, right ventricle, and then what if from here I write aorta? Aorta will be supplying to the entire body. Yeah. And then from entire body, blood will come back. Will come back in the form of Sukhe vena cava, inferior vena cava, and it comes back to right atrium. Okay. And then this is the left ventricle. This is the left atrium via mitral valve. This thing goes out. Here is the pulmonary trunk. And then from pulmonary trunk, things go to lungs, right? Oxygenated. Right? That thing will come via pulmonary veins, the left atrium, and the blood keeps on circulating. This is what? This is crazy. You know? This is what is called as the parallel circulation, right? Parallel circulation. But this is crazy, because from where the blood will, from where the body will get its oxygen, right? Because these are the two independent circulations which are going on. This is what is called as the transposition of great arteries. This means aorta, it comes out. Aorta comes out from the right ventricle. And from left ventricle comes out is the pulmonary trunk. Rest of the entire system is okay. But this is what is called as the transposition. switching positions. They switch their position. Now, if I ask the reason, why should this thing occur? Just simply because that rotation did occur. Rotation was what? Truncus arteriosus, a septum is developed, and then this will develop pulmonary trunk, and over here this will develop the aorta. But then as they are developing, it rotates, right? So that aorta goes over here, that is, this side is left ventricle, so aorta goes out of the left ventricle, and this is the pulmonary trunk. What if the septum has developed but that rotation didn't occur? So that this aorta, it will keep on coming out from right ventricle, and pulmonary trunk is from the left ventricle. So here there are two types, dextro-TGA and levo-TGA. Just for few minutes, don't worry about this, right? We'll come back to this. Before that, we need to know this part. This part, when you speak, it looks impressive. When in exam it is asked, when options are shown, then they feel that what is this? Bada easy. Because it is asked that in transposition of great arteries, there is atrioventricular concordance, atrioventricular discordance, ventricular-arterial concordance, or ventricular-arterial discordance. And then people get confused. Ye kya hai? Itna yaad rakho. Concordance is happy. Discordance is like a disease. Unhappy. So in transposition of great vessels, now you tell me, is there any jhagda between atria and ventricle? Is there?
No.
No. Right? Atria is fine, ventricle is fine. Right atrium to right ventricle, khushi via tricuspid, left atrium to left ventricle via mitral, must. So they are happy. So that means there is no problem between atria and ventricle. But then think about, are the ventricles and the arteries happy? No. Ventricle will say left ventricle ke kahan gayi meri aorta, and right ventricle will say kahan gayi meri pulmonary trunk. They are not happy. So that's the meaning of it, right? This entire statement, again, as I marked, many times it is asked. Atrioventricular concordance. Concordance means they both are fine with each other. And ventriculo-arterial discordance, that means there is a conflict between both of them. So now it is clear. Doubt ho to puch lena, right? Because there is so much to cover, so that's why I'm proceeding further. But in case of any doubt, just let me know. So right atrium to right ventricle to aorta. Galat. Right? So that's why this is discordance. Left atrium to left ventricle to pulmonary artery. Galat. So that's why this is discordance. So this is also unhappy. This is also unhappy. Survival. Bache kaise? Right. So first we pick up. Now from now onwards we'll be calling transposition of great arteries as TGA. Right? Transposition of great arteries. So first we are taking DTGA, dextro-TGA. Dextro-TGA, right? It is easy. What we saw right now was dextro-TGA. Abhi jo dekha, right? This is dextro-TGA. So it means what? There is complete TGA. Complete ka matlab this. From right ventricle, aorta is going out. Left ventricle, pulmonary artery is going out. Or the pulmonary trunk is going out, with intact ventricular septum. So then it is called as type 1. Right? Second, complete TGA, but there is ventricular septal defect also. So over here, if it is ventricular septal defect, I'll show you all the cases. Right? All the cases. Just in a minute. Ventricular septal defect. If there is ventricular septal defect, so it is called as type 2. And on top of it, if there is complete TGA plus ventricular septal defect plus pulmonary stenosis, pulmonary stenosis. So that pulmonary artery or the pulmonary trunk that is narrow. So then it is called as type 3. This is most common, in which there is transposition of great arteries with intact ventricular septal defect. Right? This is intact ventricular septum. Right? Defect nahi hai, my mistake. Intact ventricular septum. That's it. Right? So that is 50%. Complete TGA with VST is 30%. And complete TGA with VST and pulmonary stenosis is 20%. Now let's see this. And if the question has arrived, will the person be able to survive? Yeah, person would survive. From here, everything is wrong, right? Pulmonary trunk, and it is going to lungs, and this blood is going back to this left atrium. This is left ventricle. Koi scope nahi, right? And then over here, this is right atrium, to right ventricle, to entire body, and then this blood is coming back. But remember, we have got two great things before birth. Foramen ovale, right? This foramen ovale is our trump card. Blood gets mixed nicely, right? So this is where the blood will get mixed. So the body will keep on getting the mixed blood. In any case, body is getting mixed blood, right? Because we saw that thing in fetal circulation. Baby is never getting the pure badhiya blood. It is always a mixed blood. And still, if something is left out, so that is this connection, right? We drew it bigger, but this is for understanding. This connection, it is ductus arteriosus. You know? So as such, these two things, so they are already there by default, ductus arteriosus and the foramen ovale. So no problem, right? Even with this thing, it is the mixed blood, that khichdi blood, right? That thing is moving and body is growing. Baby takes birth, right? Badhiya. The trouble starts when the baby is born. Now comes the trouble, right? So this is the angiography, because this thing will explain everything in complete detail, right? Your clarity will be absolutely fantastic. See in this what we have done. It is same patient, right? This patient and this patient, they both are same because two procedures were done. First, this one. This is the catheter. So that catheter was put into right ventricle. From right ventricle, right, the dye is injected. So this and the X-ray is taken. So what we are watching is the contrast media, right? That is the contrast media. So we can see that this is the right ventricle, because in right ventricle we injected, and the dye is going all the way into the aorta. So one thing is clear, that we are dealing with complete TGA. Right. Then we saw that this one is left ventricle. No dye is going into left ventricle, because if there is defect, so then we'll be able to sharply, right, the white flow will be seen on the opposite side. But no, it is not seen. Left ventricle is pretty clean. So that means we are having intact ventricular septum, right? So when we say this is complete TGA with intact ventricular septum, so then we stamp it as that we are dealing with type 1 transposition of great arteries, type 1 TGA, right? The diagnosis, but still we want to confirm. So in that case, what we do, we put the same catheter, we took it out and then it was put it into the left ventricle. Now it is into the left ventricle, and then in left ventricle you inject the dye and you take the X-ray. When you take that, see how beautiful. This side, right? This is the left ventricle. This is the right ventricle. Right ventricle is neat, nothing, right? And our classic classic pulmonary trunk, right? It is the dye is going over there. Now it is stamped, confirmed that we are dealing with intact ventricular septum, and this is a type 1 transposition of great arteries. Correct? So that is complete TGA with intact ventricular septum, that is no VST. So this one would be the type 1. Clear? Okay. This is another patient. Now in this, in one thing, you are watching multiple things. So we start our journey from here. Why from here? Because this is the catheter. From catheter, we inject the dye. So this is the starting point. This is the starting point. So this is the start. This dye is injected into the right ventricle. But from right ventricle, can you really see how sharply, right? See the dye is going into this direction. I just zoomed this thing because I want you to appreciate that. This is a hole, and then that's how the dye goes. This is the pattern, right? It literally trickles, right? I just zoom this thing. Right? See how it trickles, right? And then it spreads here. Right? Obviously, because it is small, less dye, then it gets diffused. But this pattern, when you appreciate it, where the star is put, that thing is the ventricular septal defect. This is right ventricle, this is left ventricle, and what you are watching over here is the ventricular septal defect. Correct? So this is the second point which you have to watch. As soon as we inject the dye, we see this thing. Then right ventricle, because the dye is getting injected into right ventricle, so large amount of dye will be traveling. So and it travels and it goes. So dikhte pata chal jaye, this is the shape of the aorta. Right? This is the shape of the aorta. That means we are dealing with complete TGA. Transposition. So this is our third point. As soon as it goes into the aorta, we know that. Right? Then there is one very interesting thing happens. Aorta, till today, we have drawn aorta gracefully like this, right? Aorta matlab it is much too thick pipe, right? We have never drawn, even in coarctation of aorta, we drew it something like this. We drew it something like this. Ek jagah it kinked, thodi patli ho gayi, right? And it led to some complications. That is the back pressure and rib notching, etc. But over here, look at this. Right? So this is the vessel, right? One, it should be going on to the right side, and then that is the brachiocephalic trunk, and it will be divided into common carotid and the subclavian. And then this one is another common carotid. But see what has happened to this aorta, this arch. This arch, right? What has happened? The arch itself has become smaller. It is called as the hypoplasia. It is called as the hypoplasia. Not in every case you see this. Seen in this case, hypoplasia of aortic arch. So that is the fourth point, right? So this arch, but otherwise nothing. Everything is okay. Right? Fourth point, right? See this, and then over here there is narrowing. This is like, in this case, just from this, it would be slightly difficult, right? Because the artery has overlapped. You have to watch it in one another orientation. But this is, trust me, this is coarctation of aorta. Right? This is coarctation of aorta. That means this is the thing. The aorta is narrowed, right, as it proceeds. And then the big portion is this. This is what you need to watch. This portion. Right? Before it continues, is the descending aorta. From here, say it narrows, right? I'll just shade it like this. I'm talking about this portion. This portion. This one is pulmonary trunk, because this is the left ventricle. Pulmonary trunk. This is now descending aorta. So this portion, this is patent ductus arteriosus, because it is a duct which is between pulmonary trunk and the aorta. So that's the next finding, the fifth finding, the patent ductus arteriosus. So thus we have got, and this coarctation sixth. So thus we have got the ventricular septal defect, right? Complete TGA with hyperplasia of aortic arch, coarctation of aorta, and the patent ductus arteriosus. It is because of this patent ductus arteriosus patient survived, because such a big, huge patent ductus arteriosus, so it is allowing the mixture of the blood. Otherwise, if there are two parallel circulations, right, patient won't be able to survive. So these were the findings: complete TGA, ventricular septal defect, severe coarctation of aorta, hyperplasia of aortic arch, and the patent ductus arteriosus. Easy. Just look at it. Right? Nothing more is to be said. This is 2D echo. There is the right ventricle, and from right ventricle, right, it has been marked that yes, we can see that it is the aorta which is coming out, and this is the left ventricle, and then you see that it is the pulmonary trunk which is coming out. So definitely this is a case of complete TG. However, in this in between, if you really see, there is no VST. There is no VST. So this is 2D echo. It is showing complete, right, ascending aorta from right ventricle and pulmonary artery from left ventricle. And because there is no VST, right, no VST, that means intact ventricular septum. So that's why we'll be calling it as a type 1. Right. However, this thing, which type it is? If you remember, we differentiated it like this: that pulmonary stenosis, right, complete TGA with VST and pulmonary stenosis. Is this just after birth? That's right. That's right. After birth, just after birth. That's right. A pretty complicated case. This case is pretty, because type 2, type 3, not type 3. So how the hemodynamics? You know, hemodynamics are that there is unoxygenated blood, right? No oxygen, right? From superior vena cava and inferior vena cava, it goes to right atrium, because whatever the amount of oxygen was there was used up by the body. So superior vena cava, inferior vena cava, they are unoxygenated blood to right atrium, it goes to right ventricle, it goes to aorta, and then back to circulation. So same blood going on and on and on, which has got no oxygen. This is one. Second, oxygenated blood from pulmonary veins to left atrium to left ventricle to pulmonary arteries and to pulmonary circulation. Full-fledged oxygenated blood is circulating again and again and again, right? Not getting used. That is what is called as the parallel circulation instead of normal circulation, which is called as in series. This is one another term. Our normal circulation is called as in series. In series means there is one pulmonary circulation, one systemic circulation, right? So they both are connected with each other. So blood from pulmonary, it goes into systemic. From systemic, it goes into pulmonary. So that's how they both keep on working. That is called as in series. This is called as parallel. Therefore, without mixing of unoxygenated and oxygenated blood, patient develops severe cyanosis, hypoxemia, right? Decreased oxygen. And then there is metabolic acidosis. This metabolic acidosis is another topic. Right? Metabolic acidosis, metabolic alkalosis, respiratory acidosis, and respiratory alkalosis. these are another, they are like trump cards for medical science. For any medical student who is doing this thing with clarity, I really wish that I get a chance to teach this topic to you. Because even at a very later stage, I'm not insulting any student, but many times, even the final MBBS, they find it so kaisi khichdi bana dete hain. And when you understand it, you'll be able to say and diagnose and treat just like ECG. Because it is like step 1, step 2, step 3, and you know that what test to be done, what is to be seen into that test, and then you know what it is, right? So very dangerous thing, and will die soon after birth, mostly within 1 week. Right ventricular hypertrophy and left ventricular atrophy, right? So because of that, they die. Not much problem in fetal life, obviously, because there is foramen ovale and ductus arteriosus, right? So they are getting mixed blood and the life is good. But when they take birth, so either you have to give the ventilator support. You have to give ventilator support, and it is the immediate surgery. Not within hours, it has to be done immediate, and which is called as the switch operation. It's a major surgery, but this is what is called as the switch operation. So that is what it is. When the X-ray is taken, you will find that very typical shape, right? As if this is like an egg and it has been hanged with a string. So that's why it is called as egg on a string appearance. Again, this is only for the radiologist, right? But just to remember this shape, right? You can see kitna flat, right? Right side is so flat, and then you get this bulge, right? So this is what is called as the egg on a string appearance. When you are taking the patient for the surgery, one small step, it can make big effects on the condition of the patient, and that is, if patient is to be given one medicine, one injection, which injection would you like to give? You have got the patient of TGA, complete TGA, right? Complete TGA, and you are taking to the OT, operation theater. You have to give one injection. Which one? It will make a big difference in the outcome. And you know the answers. Answer. What will you give to keep the ductus arteriosus open? क्योंकि वो तो close होना शुरू हो जाएगा. You don't want to close it. You want to keep it open. Which one? What will you give to keep the ductus arteriosus open? That's good, Sharon. That's right. पूछ क्यों रहे हो यार? That is the answer. Don't ask, say it, right? With confidence. Yes, that's right. That's the prostaglandins. Prostaglandins, because you don't want that ductus arteriosus should close. Because his surgery is not like a magic, right? It takes time, right, before it is established. So till that point, ductus arteriosus remains open. It is good, so that blood gets mixed and patient survives. Right? To keep ductus arteriosus open. Open. Now we come to this lever, right? After that, the rest of the topics we'll take next time. But this lever, study this lever, right? It will blow your mind. I mean, when I studied it, I thought कि यार भगवान कोई क्या क्या सोचता है? Can it be diagnosed before birth? Wonderful question. It has to be diagnosed before birth, because if it is not diagnosed, it is a grave mistake of the radiologist. Right now, with super fine, high resolution, these ultrasounds, it shouldn't be a problem. But It should click in your mind that what you are supposed to do. Yes, you can. It has to be diagnosed. But this is tricky. Now, what we are about to discuss is this LevoTG. Right? No one would ask LevoTG at MBBS, but when you know, you'll be smiling. When God does the surgery by himself, we created a play out of it. Bhagwan बैठे थे, and then those Brahma ji, right? And then there was some jhagda with the Lakshmi ji, and कुछ गड़बड़ कर दी, and then दौड़ते दौड़ते आके यार भगवान गड़बड़ हो गई, right? Right ventricle में से the aorta is going out, left ventricle में से pulmonary trunk is going out. अब करो कुछ, भगवान ने कहा कि अच्छा ठीक है, तथास्तु जाओ. And then the surgery was done by God. So this is that, and that is what is called as a LevoTG. Very interesting. See what happens. अब गड़बड़ हो तो गई, right? Mistake has been done. So this is right atrium, right ventricle, left atrium, left ventricle. From left ventricle, what was going out? From left ventricle, pulmonary trunk was going out. From right ventricle, aorta was going out. So blunder has been made. Now, so God said, do one thing. Take this entire unit, and switch their positions. So here, great arteries switch position and the ventricles also switch position along with the valves, right? With valves. Now, if it is confusing, I'll just draw this entire thing again. Right? See, this is right atrium. From right atrium, it goes into left ventricle, right? Because it is switching with the valve, so here is, this valve is what? Mitral valve, right? This is left atrium. Left atrium opens into right ventricle, but because God has switched the ventricles, so this is the right ventricle. But it is along with the valve, so this one is the tricuspid valve. You know? Now, everything same. So the mistake which was done to that is still there. So from left ventricle, what will go out? Pulmonary trunk. That cannot be correct, right? Pulmonary trunk to lungs. From lungs to left atrium. From left atrium to tricuspid. From tricuspid to right ventricle. From right ventricle to it is aorta. Okay. From aorta to the entire body. From entire body to infravena cava, right? And it goes into the right atrium. Wonderful, right? This is how God did the surgery. He switched the positions, right? He switched the positions. So ventricles, they switch position with valves. Great arteries, they switch position. So that's why this is very lovingly called as, very cutely called as CCTGA. Congenitally corrected transposition of great arteries. How amazing, right? And this is like acyanotic, like normal heart, right? Bindas. You might say कि तो फिर नाम बदले ना, right ventricle to left. No, but it is along with the valves, because mitral valve is how? Mitral valve is bicuspid, so this is bicuspid. Tricuspid is three cuspid, right? So it is three cuspids. Right ventricular musculature is not that powerful, right? It is weak. Left ventricular musculature, yes, this would be very strong, right? So all those characteristics, so they are there. But this is what really happens. And when you see such heart, this is like congenitally corrected TG, and this is another name, right? LevoTG, right? So we changed it to live with TGA. And this is to remember. here that baby can live with this TGA, right? While this dextro TGA is death with TGA, right? Because it is that dangerous. D is for dangerous. So this is like a normal heart. Baby will be fine, right? But as the age increases, there is some problem. In adult, it can lead to valve failure. Reason? Tricuspid valve is as such very delicate. Tricuspid valve was never made for high pressure. Mitral valve, though there are two cusps, but they are very powerful. Their chorda tendineae, they are very powerful. So this tricuspid handling, high pressure, that valve fails. That valve fails. So many times valvular surgery is performed, and then rest of the life it goes fine, quite comfortable. The risk factors are. Then in which cases it can happen? It occurs in, so when there is PEM, that is protein, energy, malnutrition. Protein, energy, malnutrition. I'm reading a book. It's an amazing book. Right? This is what is called as the endurance diet. Right? And it is by this Matt Fitzgerald, author of Racing Weight. In fact, he is the person who has defined the diet in a very amazing way. Right? That what one should really eat so that their endurance, the power increases. Right? There are some very basic principles, but I have not yet finished the book. I'll let you know. But why I'm telling you this is protein. Protein is something which is usually missed. Right? Try to have more protein. It won't cost much, but yes, it is so important. And if expecting mother is PM, protein, energy, malnutrition, then this thing can occur. One, diabetes. Right? Diabetes is increasing in youngsters. Yes, you'll be surprised to know that. It is increasing. It is because of one, stress. Right? I'll not blame you at all because there is so much of pressure from the parents, so much pressure from the society, from this media, right? अरे तू डॉक्टर बनने वाला है, अरे तू डॉक्टर बनने वाली है, then there would be some गाली बोलने का मन हो ऐसा, अरे ये डॉक्टर बना कुछ नहीं किया, उसने सुसाइड किया, this that all those negativity. I saw some stupid serial, एक दो एपिसोड देख के बंद कर दी थी. I mean so much of negativity. क्यों? Then there is pressure, and then the peer pressure. It is, that's why मैंने बोला है कि even whether our classes are continuing or not, whether you are in touch with me or not, but any day if you feel depressed now, if you are happy, you won't write to me, I won't mind. But if you are sad, if you are having any trouble, do write 2-3 lines. Right? I have given even my phone numbers to many of the students. So, ठीक है, बात कर लो यार. There is, you are the most precious. Right? So stress, that is very bad thing because it leads to this diabetes. And how come? Insulin resistance. Second, lack of exercise means for hours together you are studying, but spare some time for it. And third thing is the junk food. This is the very big thing, junk food. And in this is a killer, MSG, monosodium glutamate, which is put into almost every food, every burger, every pizza, because if they don't put this, then it won't sound that tasty. Right? You tell your mom to make burger, and even if she is the best cook, she won't be able to get that taste, which is by that bahar ka burger, right? Because they put that monosodium glutamate. Monosodium glutamate, which really affects your brain, right? And it has got so many harmful effects. Can speak on for hours on it, but just avoid this thing. Right? So be happy and exercise. Your physical fitness, it is very vital. Otherwise, those you'll become super powerful, mast ekdam, super specialist, badhiya cardiologist, neurologist. But what's the point if your health is not that good? So then the entire money will be of no use. You won't be able to enjoy it. Alcoholic, I'll be very blunt on this. To be very blunt on this. Being to all these countries, मतलब मेरी जहाँ पे आप लोग हैं अभी, वो country बाहर के सब all, Georgia, Kazakhstan, Kyrgyzstan, this, that, everything. Don't fall into this trap कि बहुत ठंड है, because it is very cold. That's why I need to have that alcohol. Alcohol affects your brain. Alcohol affects your liver, right? And it affects badly. Right now you are young, your power is so high, so you won't realize it. But then later on it will make a big difference. And I really want that kabhi bhi aisa man bhi ho, right? When you feel that yes, now I'm a bit shaky, drop a line, right? Drop a line. एक मेल भेज देना, will definitely down. Age more than 40 plus and the rubella. These are the high risk factors for any of the congenital heart disease. Right? That's why it becomes a prime responsibility for every female to take very good care of her, and for a male to take care of our female. All right, so we stop at this point. Right, regarding this truncus arteriosus, which is again a very fine thing, then hypoplastic left heart syndrome, and then the most amazing total anomalous pulmonary venous return. Right, we'll be discussing it day after tomorrow, and thus we'll be completing congenital heart disease, and then we'll proceed with the next topic. All right, wish you all a very happy Diwali, happy New Year, take care, and see you soon.